Generative AI is so different. It allows not just knowledge. You go to Google and you search a concept or a term, you'll get a lot of links and a lot of information, but you don't get expertise. You can't do that much with it. A generative AI tool is capable of expertise. You can paint like a Rembrandt, even though you've never had an art course. You can program a computer, even though you've never had an IT course. You can write a song that sounds like Drake of the Weeknd, even though you don't play an instrument. And as a patient, you now have abilities to manage and understand both your acute and your chronic disease.
Hi, I'm Chris Malone, and I'll be your host for today's discussion. Thank you for joining us. Before we begin, I'd like to thank our sponsor, Feedback Now, for their support of this program. If you've ever seen the happy and sad face buttons in an airport security line, retailer, or restroom, those may be very well from Feedback Now. And they're actually connected to a robust operations and data analytics network. This comprehensive solution takes real-time data from across healthcare operations and highlights where teams need to focus to improve patient experiences and reduce nurses' non-clinical workload. I'd also like to once again welcome our friend, colleague, and program partner, Michael Giuliano. Michael is president of Planetree, which is a global not-for-profit organization dedicated to humanizing healthcare for everyone through excellence in person-centered care. Welcome, Michael. What can you tell us about our guest for today's program?
Thank you, Chris, and welcome everyone to this November episode of Humanizing Healthcare. It gives me great pleasure to introduce Dr. Robert Pearl, professor at the Stanford University Schools of Medicine and Business. Robert's latest book, ChatGPT MD, How AI Empowered Patients and Doctors Can Take Back Control of American Medicine, was published earlier this year and written collaboratively with none other than ChatGPT. All profits from Dr. Pearl's books go to benefit Doctors Without Borders. And Robert's insights on AI have been widely covered in the national press and healthcare industry-specific media. We're so happy to have Robert join us today for what promises to be a lively discussion about a very hot topic that is top of mind for all of us. So thank you again, Chris, and welcome Dr. Pearl to this episode.
Thank you, Michael. It's a pleasure to be here, and thank you, Chris, for inviting me.
Very glad to have you. Now, Robert, we would love to hear the story, if you can share one, about how you found a path into a career in healthcare. Is there anything in particular, an experience or memorable moment that led to that?
My path has been one of serendipity. When I finished high school, I was 17 and went to college to become a university professor. And in my freshman year, my mentor, a brilliant teacher, didn't get tenure. Not because his research wasn't great, he became the chairman at Reed College, but because of his political views. And I decided at that time that I did not want to be in a profession with politics, and I was certain that if I ever tell a 17-year-old that healthcare would have no politics. For after all, it's about life and death, and it should be measurable and easy to accomplish. Boy, was I wrong.
Well, that is a great story. Now, you were at Permanente Medical Group for 18 years, former president of their Mid-Atlantic group, leading over 10,000 physicians and 38,000 staff. What are some of the highlights of your time in that role, and how has that informed the thought leadership work you're doing today, all about technology?
So I was the CEO in Kaiser Permanente, the Permanente half. The Kaiser side is the insurance part, and the Permanente side is the delivery system. And I was that both on the East and West coasts. But when I arrived at Kaiser Permanente, or when I became the CEO, I should say, inside Kaiser Permanente, the organization was in big trouble. We had lost hundreds of millions of dollars the previous couple of years as the for-profit companies had come into the industry and slashed care and slashed profit. And we were down to 2 days of cash. We had to borrow a day of cash in order to stay in business. The CEO stepped down in the midst of all of the calamities that were happening. And again, it was a moment of serendipity. I thought there were several people who could do a great job leading, and I approached them. And within the medical group, the CEO was selected by the clinicians. And I suggested they step forward so I'd support them, help them in any way. And they said, "Are you crazy? It's a terrible job. We're about to go out of business. What are you talking about?" And so I felt like I had no choice but to step forward and take on the reins. And what I realized is that the model of the past, that Kaiser Permanente's main differentiation would be about being a lower cost organization, which you would achieve of preventive care and lower cost care, that model was not going to be successful going forward. Medicine had just changed too much. The technology had advanced, drugs had come along. There was no way to be able to be priced 15 to 20% below your competition unless you had a different means of doing so. And so I quickly shifted the strategy to one of quality of service differentiation at a competitive price. At the time, we were good in quality, just not outstanding. We became number one, NCQA. Very proud of that. And NCQA is a tremendous organization that measures things like the ability to prevent colon cancer and heart disease and be able to manage chronic diseases when they arise. And that's what we saw. The rest of the nation was 55 to 60% control of hypertension, which accounts for 40% of all strokes. We got to over 90%. Colon cancer should be a disease that's far more preventable than today. The nation was doing maybe around 50, 60%. We were 90% of the time. Hospital-acquired infections and other preventable medical problems were rampant in the country. 250,000 people dying every year. We reduced that number by 75%. Every place that we could make an improvement. And the second thing I'm very proud of is that we focused on maximal access. We looked at the issue. If you're going to see a patient, it's no harder to see them today or tomorrow than it is to see them a week or 2 weeks from now. Across an entire year, you see exactly the same number of people. So we saw 70% of routine problems same day or next day. And we were able to connect specialty and primary care so that the specialist using technology would go into the exam room when the patient was still there. And so we could move care forward. We were able to reduce the cost, not by limiting in any way the number of people that we hired as our, I'll call primary drivers, you might in a typical medical group or industry, but no, by continually adding expertise to get care to improve. And we went from a market share of 34% to one that was 46%, which is a pretty fast increase in less than a decade.
Well, that's really remarkable. And how you were able to accomplish that, I'm sure we'd love to hear a little bit more about. But today, we're especially interested in the topic you wrote about in your book. And what inspired you to write a book about generative AI and the decision to co-author it with ChatGPT?
If you go back to when I was the CEO at the time before ChatGPT, what we were able to do was to focus on opportunities to prevent and better manage chronic disease, but we did it with a lot of people. We did it with a lot of nurses and pharmacists. It's part of the reason why our clinicians were much more satisfied, 20% higher satisfaction than the other physicians, both the East and West Coast. But costs keep going up. Why is that? Because people are expensive. And so what I realized is that we had to do something very different. We had to use technology in a way to elevate quality as the means to drive down cost. Think about that. If you look inside medicine, show me a single example of technology that we've put in place in the past 20 years that has accomplished that. The technology we use has increased quality, but it's driven up cost. We haven't had a tool. And suddenly, by the way, a couple of weeks from now, it's going to be the 2-year anniversary. ChatGPT, and I use that because I love ChatGPT MD, the flow of the title of my book, but it's also Gemini and it's Claude. It's really any generative AI tool. Now, suddenly became available. And with that tool, we, for the first time, could not just help doctors do things better. That's what an MRI does, or a CT scan helps improve the diagnostic accuracy. But we actually could empower patients. See, generative AI is so different because it allows not just knowledge. You go to Google and you search a concept or a term, you'll get a lot of links and a lot of information, but you don't get expertise. You can't do that much with it. A generative AI tool is capable of expertise. You can paint like a Rembrandt, even though you've never had an art course. You can program a computer, even though you've never had an IT course. You can write a song that sounds like Drake of the Weeknd, even though you don't play an instrument. And as a patient, you now have abilities to manage and understand both your acute and your chronic disease. But what I realize is that this technology is doubling in power every year. That means that 5 years from now, it's going to be 30 times more powerful than today, which is really important. But it also meant that if I follow the usual publishing route, a process that my previous 2 books, Mistreated and Uncaring, took about 2 years each, that by the time the book came out, it would be so out of date that no one would be able to learn from it. And so I asked myself how to solve this problem. And it seemed to me that a generative AI tool was one way to accomplish it. And I approached it the way you do with a medical student or with a resident. I started by having the technology read the 1.2 million words that I had previously written at that particular time, so it knew the way that I thought. I then sent drafts. So I wrote some, ChatGPT wrote back and forth. The typical chapter has 30 different back and forth edits that were responsible before we got to the end. There are 6 pages in the book that ChatGPT wrote alone. I highlight those so readers know what they are, just so they could see what was there. But I believe that the combination of ChatGPT and myself was better able to create text than actually either of us alone. I think the same thing is going to be true in medicine. I will say that I fact-checked everything that ChatGPT wrote. There's a 30-page bibliography. And I did find one major hallucination. It invented an expedition to the Arctic Pole that I can't find any evidence of that it actually occurred. And if any viewers and listeners are able to find one, please tell me so I can apologize to my co-author. But that was the process. And I also wanted to demonstrate what's possible is possible both in medicine, in writing, in publishing. I think at the time I could see that this tool would transform every industry, but particularly medicine. And now, I'll say less than a year after I started, I'm convinced that if anything, I underestimated the potential that exists.
Wow. Now, you mentioned earlier the relationship between cost and technology and how cost sometimes improves care but increases cost. But I also know that you're a proponent of value-based care arrangements as well. Where do you foresee the intersection between generative AI and healthcare and cost?
I think generative AI will first, it's going to save, I think, even hundreds of thousands of lives a year, and it actually will make care far more affordable. But let me explain why. We know that medicine is suffering today. Inflation is now down nationally to about 2 to 3%. Healthcare inflation next year is going to be 7 to 9%. We know that half of Americans can't afford the cost of medicine today. It actually, during the presidential election cycle, in polls that were done, healthcare costs were seen as more significant than gas prices or grocery store prices. We are at a crisis point when it comes to the cost of providing care. And I think we're going to start cutting back and compromising care for growing segments of the nation. The other thing I want to point out is burnout. Over half the doctors are burned out today. I want to ask myself, why are all these problems here? The world often wants to see villains. I don't see villains. I try to find the underlying driving force that's existing. And I think it's the epidemic of chronic disease. If you see a patient with right lower quadrant pain, you diagnose appendicitis, you take out their appendix, maybe you see them 5 times across a couple of months. As soon as a patient walks into your office with diabetes, you're going to see them 120 times over the next 30 years. It's a tremendous increase. And a third of Americans either have diabetes or pre-diabetes today. And when I look at chronic disease, I think it's the greatest opportunity. The CDC looked at this question of what would happen if we could manage chronic disease, not perfectly, let's just say as well as Kaiser Permanente did, using a lot of people. Let's set that as the bar. What would happen? 30 to 50% fewer heart attacks, strokes, kidney failure, cancer. Just ask yourself, what would happen if our nation had 30 to 50% fewer heart attacks, strokes, kidney failures, and cancers? Health would soar and costs would plummet. That to me is what value-based care is. Value-based care to me is you drive down costs by raising quality. You drive down costs by improving access. But you don't do it in the traditional model. You do it using new modern tools. And that's where I see generative AI coming into play. I teach at the Stanford Graduate School of Business as well as the medical school. And across from the Graduate School of Business is the engineering school. You go there, what you'll see is that they have Band-Aid-sized monitors, wearable devices, that with 99.9% accuracy can tell you your blood pressure, your pulse, your blood oxygen, your blood glucose. Let's say you're a clinician. A patient walks in, you put a blood pressure cuff on them, you measure it. They have high blood pressure. You retake it later that day, they still have high blood pressure. And so you start them on a medication, and you say, take this medication, I'll see you in 4 months. What happens during those 4 months? We have no idea. A wearable device is capable of, let's just say, measuring your blood pressure 3 times a day for a month. At the end of a month, you have 100 readings. 92 are normal and 8 are abnormal. How are you doing? I'm doing great. 92 are normal. No, I'm doing terribly. 8 are abnormal. You just don't know. And there's no clinician who wants 100 blood pressure readings sent to their office every month. For generative AI, it's a simple first and second derivative calculation. And if after a month the blood pressure is getting better, keep waiting. Check it the next month, the next month, and the next month. There's no need to see this patient as long as they're continuing to improve or following the trajectory that you thought. And on the other hand, if after a month it's going the other direction, the time has come to change the dose or change the medication. This is the real opportunity. Moving chronic disease management from treating the complications to preventing the complications. Moving chronic disease management from being episodic to continuous. And I think if we did that and we had the salutary impact that's predicted on heart attacks, strokes, kidney failures, and cancer, we could have a tremendous solution to the point you made that would raise quality, lower cost, that we would actually have a true value-based system of medicine in the United States.
That's a really interesting point that you make, that the key to this is not simply treating the same number of patients with the same number of conditions less expensively. It's all about intervening and influencing the prevention of those chronic diseases before they reach that state and basically eliminating the cost associated with that. Whereas you don't hear that very often now, I think, in the healthcare marketplace.
You're absolutely right. And I think part of the reason for that is the economics. Remember, we call it fee-for-service. We basically have a 19th century cottage industry method of piecemeal reimbursement. The more you do, the more you get paid. Whether there's any good or not doesn't matter. See a patient twice for a problem you could solve once, you make twice as much money. In fact, often if you do a procedure and get a complication, not in Medicare, but in commercial insurance, you get paid twice, once to create it, once to correct it. It's, what does Charlie Munger say? Show me your incentives, I'll tell you the outcomes you're going to get. We have a system that incentivizes higher volume. And we need a system that rewards better clinical outcomes. We actually need a system that is going to reward people based on not what did they do, but the outcomes they got. Did the blood pressure come down? Did the blood glucose come more towards normal? Did the patient with heart failure avoid admission to a hospital that year? These are the measures we should be using. But in a fee-for-service world, that doesn't work. And it's why I'm a big proponent that in parallel to the introduction of this technology, we need to move to a capitated system. And I don't mean capitation at the insurance level. That doesn't work. Because the insurance company has no choice whether to pay clinicians on a fee-for-service basis, and you're right back where you started. No, I mean capitation at the delivery system level, paid directly to doctors and hospitals. Once that capitation is in place, I'm confident that they will come up with brilliant ways. I have massive respect for the innovation and for the ingenuity and the commitment and dedication of clinicians. And if they have the right incentives, if they have the right financial structure. In the book, I write about the fact that any technology that either slows doctors down or compromises their income will never be implemented. Not because doctors in any way are bad, but because none of us would do that. You can't sacrifice your family no matter how much you might like to do something differently. Capitation combined with technology to me is the solution, keeping patients healthier. In Kaiser Permanente, we were able to reduce heart attacks and strokes 30 to 50%, just like the CDC said, but did it through people. Now we can do it through technology. We were able to lower the chances of patients dying from cancer. Similarly, now we can do that technologically. I think we have to stop, look at the problems of today, and commit to a different solution for the future.
That's an excellent point. Hey, let's take a short break, hear a little bit more about Feedback Now and how they're elevating experiences for hospital inpatients, visitors, and nurses. Let's take a look.
Wasting staff resources is expensive. Overstaffing drains budgets, while understaffing risks quality and patient satisfaction. But without real-time visibility, it's impossible to strike the right balance. Instant alerts from Feedback Now notify your EVS team when and where cleanliness metrics change. This data-driven approach allows you to rapidly redeploy resources to maximize efficiency without sacrificing standards. Don't let poor visibility into your operations hold you back. See how real-time insights can transform your hospital at feedbacknow.com.
From what I hear, part of what they're finding very appealing about Feedback Now is this notion of real-time data that will be used actually in artificial intelligence applications for staff deployment and management. So it does kind of tie into our topic a little bit there. But, before we get too much further, I want to get your thoughts on kind of the human side of healthcare. Over the last few years, there's growing interest in the idea that healthcare needs to be more human, and kind of in use thinking about AI, where does the human element come in and the patient aspect of this? Is that something that is going to diminish interactions at an interpersonal level between patients and clinicians, or does it perhaps enable more of that?
I think it will improve it dramatically. I think today we are suffering without fully acknowledging it. When you have 17 minutes with a patient, which is the average that exists currently, you just don't have the ability to dive anywhere near the depth that you need to go. By the time you address the acute problems, do some medication reconciliation, reorder prescriptions and the standard tests, you're done. You haven't gotten into any of the personal aspects that exist. The biggest challenge, I think, for doctors today is insufficient time. And we can't create sufficient time just by doubling the number of providers. First, it would take too long to train them, and number two, the costs would be too high. No, we have to figure out how to use this technology to accomplish it. Now, I was on a podcast a couple of months ago. At the end of the podcast, as often happens, the cameras came off and the podcast host said to me, Dr. Pearl, you're a skier. You are a doctor. My husband fell about 3 months ago. His arm was over his head. He slid down about 100 feet. He still has pain in that shoulder and can't use it like the opposite side. What's going on? And the host had told me that she had never actually used a generative AI tool. I said, you know what? Why don't you go home, use the free ChatGPT and put all the information in place and ask it, what's going on? And after that, give me a call back and let me know what it said, and I'll tell you what I think is actually happening. 5 days later, she calls back and says, thank you so much. We did exactly what you said. And ChatGPT said, number one, he probably had a torn rotator cuff. Number two, he did an MRI. And number three, he should see an orthopedic surgeon because the treatment is almost definitely going to be surgery. Now compare that to a Google search. You'd get a lot of information. You'd have 100 different possible causes of shoulder pain or arm dysfunction. You'd be told to see an orthopedic surgeon to protect Google, not to be able to recognize that in your unique situation, this is going to be the treatment almost definitely that's needed. So now imagine what happens when that patient comes in the office and the clinician says, I think you have a rotator cuff tear. And they nod their head because they know what that means. And you need to have an MRI. And they don't question it because they know exactly why it's being done. And I'd like to schedule surgery because the MRI shows that you have the torn rotator cuff. And they say, great, when can you do it? This is a very different doctor-patient relationship. It's not the vertical hierarchy of the past. It's very much going to be a collaborative way that things are done. If you look at what goes on today, and I really liked your commercial because it highlighted the fact, if you just have your team go around to every unit every half hour and the one you just left has a spill, you're going to be back there in 4 hours. You just don't know what's going on. That's what happens now. I'm in very good health, but I've had a lot of accidents, skiing off cliffs and other things like that. So I spent some time in a hospital. A nurse comes by at 8 a.m., comes back at noon. What happens to those middle 4 hours? We have no idea. There's monitors at every bedside, but what are they set for? If my heart stops, they'll tell the nurse so she can come in and resuscitate it. No, we want to know what went on during that transition. The same thing in the doctor's office. We see everyone on a routine basis every 3 or 4 months, unless they have a really acute problem that rears its head. No, we want to monitor people and bring in, out of every 10 people, the 2 or 3 individuals who need my personal touch and not take the time of the other 7. The other 7 want to know that when they have that big problem, they can come in. They want to know that I'm following the information and I'm readily available to them. But now I have, instead of 17 minutes, I have 45 minutes. And I can ask about their family and their problems at home. I can go into some of the social determinants of health. I can do the things that we know change medical outcomes, but we just don't have the time to do it. I can actually focus on the chronic diseases and understand what they're not able to do. So I think it's going to actually take us back to the day when I think the doctor-patient relationship was a true relationship, rather than today when it tends to be very transactional.
Excellent point. And I guess the fact that you are able to have AI monitor what happened between the last time I saw you, don't have to spend time asking patients what happened since the last time I saw you.
Exactly.
Now, but what about the privacy and security aspects of this? That is such a hot topic with health information that's private and patient related and so forth. What is your sense, having led an organization that had to secure that stuff, as to whether AI can be relied upon or what stage it's at as relates to security?
Absolutely. So security is a big problem in society. Every time you have a computer and people, you have a security risk. Every time I do something with a bank, I have a security risk. I'm sure a lot of people would love to be able to get into my bank account and take the money out of that. Every time I go on my computer, I run that risk. And we see that. We saw ransomware with Change Health that brought down a lot of the systems that exist right now. This technology, I don't see any reason why it's going to make it any worse. It's the exact same set of problems. And, I like to believe that these companies that are the largest computer companies in the world are going to have the best engineers and have the best protection. I don't deceive myself. The risk is there. It's just the risk that exists in every single thing that we do. Privacy is a different issue. Here, I think that the generative AI tool will have more privacy. Think about it. How do most companies, Facebook is a good example, or Google, how do they make their money? They make it by selling access to individual privacy data. There's a reason why the minute after you Google pregnancy test, you get ads for diapers. There's a reason why these changes happen. As soon as you put in anything about diabetes, you're going to get a whole lot of advertising specific to monitors or test strips. Generative AI tools, at least so far, are subscription models. And so I think there's a higher or a lower risk of using these tools. Not to say it couldn't happen, because once your security is violated, your privacy can be violated. But I think that as a business model, it's a better business model to protect the consumer.
Right. A subscription revenue model rather than a data sale revenue model. So we've got lots of healthcare clinicians listening, quality executives, patient experience executives, and you've worked alongside them in a large organization. What advice or coaching would you have for them about how they should think about generative AI impacting their world going forward, and how they can, any rules of thumb about how to get stuff done in this world? Because that's always the hardest part. Great opportunities and great ideas, but getting things done and change in healthcare is often challenging.
The first thing I say to people is that as humans, we always see the faults and frailties of technology. We rarely see that of ourselves. So the first thing is for us to acknowledge the data that exists. Why is it that we control hypertension only 55, 60% of the time? Why do we only screen for colon cancer 60% of the time? Why do we appropriately manage diabetes in terms of blood sugars less than that, probably 30% of the time? Why do we have 250,000 people dying from preventable medical errors? I mean, think about it. We know what to do. Johns Hopkins has published the data. We just don't do what we know we should be doing. And so we often come up with an excuse for that rather than embracing that data and saying we can and we must do better. When you start to look at that, it becomes a hard problem. We've worked at it for a long time. It's not that well-motivated people haven't wanted to do it. So actually, they didn't have the data. They didn't have the tool to accomplish it. And when you start to look at that, you quickly realize that we need to make a change in how we are providing that care. You know, it's interesting to me that in the hospital, what we know is that there's a certain number of people who will deteriorate across the night and require admission to the ICU. What we know is that once they require the admission to the ICU, their chances of dying in the subsequent 3 months is 4 times higher than if we address the problem, they never have to go to the ICU. And yet, we don't do anything to change that. Yes, we like to talk about telemetry. That requires a nurse to sit at a monitor. There's only a certain number of beds that it can happen. Generative AI can accomplish that for us. You know, we need to be able to look at all the patients that are there and ask ourselves, who are the ones at greatest risk? How do we reshape the time that we spend with each? You know, we've relied on the medical order, see the patient every Q1 hour, Q2 hour, Q4 hours. On what basis? We don't have an optimal approach. We have the data. I'm going to give you a very amazing statistic. If you look at all the monitors that sit at the bedside of hospitals today, they produce a petabyte. That's 10 with 14 zeros after it of data. Take a guess how much of that data we actually ever use in any way, shape, or form. 3%. 97% of the data we throw away. Why do we do that? It's not that it's not valuable. We just don't have the people, we just don't have the time to be able to use it. That's what the big opportunity exists today. We can take all the people who are in a hospital who may be having a problem and be able to intervene, not when the crisis strikes, but 2 hours earlier, avoiding that crisis. We have a maternal mortality problem in the United States today. It's the worst of not only all the other 9 most industrialized nations, it's worse than the top 2 put together, the next 2 put together. We just don't have the tools. We try to do it all through education. We now have a technology that will assist in that process. So what I would say to people is start by recognizing the shortcomings and then ask yourself, how can this technology be applied in ways that are going to allow us to overcome them at a cost that we can afford?
Great. Let's take a few questions from listeners. First, we got a question from Omar Etma, and he asked, should I study prompt engineering to maximize my productivity from AI, or will that be unnecessary because of the pace of improvement in things?
You're absolutely correct that the quality of the answers you get is based upon the prompts that you give. And it's not just the first prompt. That's what differentiates it from a search engine, because you could engage in a dialogue, and that process has become a lot easier now with a newer version of ChatGPT, having the ability to just have a conversation. And the conversation flows like any other conversation, like you'd have with a colleague in a hospital, like you'd have with a mentor. And that ability to ask the questions, it actually takes about 10 hours, but it's just practice. It's not a question of, taking a class or memorizing. It's pretty intuitive once you try it. And that's what I tell people. This is the time, this is not yet the time to use this completely independent of clinicians. That day may be coming in 3 to 5 years when it's 8 to 32 times more powerful. But it is the time to get experience and expertise. Pretend you're the patient, the one you just saw in the office today. Put the data in as though you were at home before you saw the clinician and see the response. And then ask another question and see the response. And you'll be able to very quickly understand the more data you provide, the more specific it is, the more you're accurate about what you're looking for, the more likely you are to get the right answer. And that's a learned process. And then put it as the clinician. You know, I like to tell the story about a close friend of mine. She was operating. She did a very complex neck procedure. And at the end of the case, she knew it had gone technically perfectly. The anesthesiologist said the vocal cords were stuck together in the middle. They were adducted. He couldn't take the tube out or the airway would be blocked. Do you want to know, do we go to the ICU? Do you want to do a tracheostomy? What do you want to do? She pulled out her phone. She went to ChatGPT. She found 4 cases in the literature in a matter of half a second, exactly like this. And what she realized is that we inject into the neck a local anesthetic, but not because of the local anesthetic. We inject it because of the adrenaline. We want the blood vessels to constrict so we have a bloodless field. And sometimes that diffuses, and it can diffuse from the neck itself into the area of the larynx, the vocal cords, and it can paralyze the muscles that were there. In every case, once the anesthetic wore off, the problem went away. And she said, no, let's just sit here for 30 minutes. 30 minutes later, the cords separate, tube comes out, patient goes home. That is the opportunity that exists right now. What we know is there's 400,000 people a year in the United States who die of misdiagnoses, another 400,000 who are harmed have long-term disability from a misdiagnosis. How do we use this tool to make sure we're getting the right and best answers? These are the things I encourage every clinician to play with and learn from. Not perfect, still with restrictions, but far better, I believe, than what we do currently.
Very interesting. We have 2 questions from Sheila Maroney. First part, generative AI is going to be incredibly powerful in healthcare for sure. How do we ensure that we don't abdicate responsibility for paying particular attention to those who are not very tech savvy?
I love this question because I think it's more than an issue of who's, then, quotes, not tech savvy. I think there's a lot of patient education that needs to happen. And I find it strange that we even think about every doctor figuring out for him or herself. Why don't we have the large national organizations create this information from patients? How to use it? People who are 13 years old, they just take any new technology they use and they figure it out very, very quickly. But people who might be a bit older, they like to have instructions and information. We can have links. It could be online. It could be through YouTube. It could be classes. There's so many ways that we could do it. And if we did it at a national level, the cost per doctor would be pennies. So that's what I think that we need to do. And that would allow the clinician to tell the patient, why don't you go home? Click on this link. It's easy to do. If they don't know how to click on a link, here's a YouTube channel you can see. And why don't you try using this technology for the problems that you had? See how different it would have been today had you come to my office with this in place. See the opportunities to learn more about your chronic diseases. Every Sunday night, my wife and I, we sit down with ChatGPT and we create the shopping list for the week. Sometimes we maybe had a couple of big dinners that week. We want to have a little lower calories the next week. Sometimes we want something different. We give the technology all the tool and it gives us menus for the week, a shopping list, recipes. That's the kind of thing that's so easy to start to learn on. And by the way, it can do it in 53 different languages. Now, we have a tremendous tool in our hands. We just have to decide how to use it, and as part of that process, to train our patients on the ability to be able to enter the information. It's, by the way, made easier now with the 4.0, because that's simply now going to be a language conversation. So they don't have to type anything. They can just engage the same way they would with a clinician. And it's going to get a lot better when 5.0 comes out in less than a year.
Got it. Second part of Sheila's question is more on the human side of things. Since AI is not technically capable of empathy, how do we make sure that patient's biography is integrated into the conversation and that the clinician understands how they feel emotionally and what's important to them?
This is so beautiful. I love this question because the assumption that it doesn't do empathy is exactly wrong. And I don't say that in a negative way. It's just there were studies out at the University of Arizona. They took the messages that patients sent doctors. These were actual messages that the clinicians responded to. They gave the same questions to the generative AI tool, and it created its own responses. Then they took the responses from the doctors and from the AI tool, and it showed it to a bunch of patients as well as a bunch of clinicians. It found that the answers from the generative AI tool are 4 times better than the clinician ones, and the degree of empathy shown as evaluated by patients was 9 times greater. No, it's exactly the opposite. Empathy requires that you have a viewpoint from the patient side, and this technology is actually very, very good to do it. It's able to remember things about the families, the friends, the personal issues. I think we're going to find, in fact, it's one of my big worries, that we'll become as dependent upon that to show empathy as we are to drive our cars using one of the tools on our dashboard, and we're actually going to wither in our personal ability to do so.
Well, I have to tell you, I'm personally a little skeptical on the empathy from AI from the standpoint that if you know that it's coming from an AI and not a person, will you feel the same way about it? AI certainly has a greater capacity, more time and more words to kind of, show empathetic language and so forth. But whether we'll feel the same way, I don't know. We'll have to see. Last question here from Mark Zitter. When and how do you expect chatbots will be used for mental health purposes, including psychotherapy, monitoring patients with significant disorders, and things of that nature?
Again, I love this question because it poses a very, I'll say, complex quandary for any of the technology people in the audience, which is, do you give the patient directly the generative AI tool or do you create a chatbot? And the challenge of doing a chatbot is that you then have a certain degree of liability. And I think that will actually be the limiting factor. We already have tools that I'd say are good. It's only a matter of training. If we can have access to 100,000 doctor-patient interactions, this technology is going to get better. But by the way, when I speak at companies, they actually think they have the ability to get to that data and be able to accomplish that. I don't think it's going to, again, I don't think any of these things completely replace the clinician. There's a level of complexity. If I have cancer, I really do want to talk to a human. I really don't want to talk to AI tool, I want to talk to it, but I don't want that to be the only answer, even though it may be more technically accurate. There is something about, I'll call it the illogical nature of human emotion and behavior that actually the technology has trouble understanding that illogical aspect to it, as well as a human being can relate to it. And so I think that the same thing is going to be true in mental health. We see patients now often every 2 or 3 weeks. Why is that? Because there's not enough mental health clinicians in the United States today. What goes on between those sessions, we have no idea. And again, this is where I think, just like in the nurse example, it can fill in. It can monitor the patient in whom there's always some concern and depression. Is this patient going to be suicidal? It can monitor the ideation of patients who might be schizophrenic. There's a lot of different things that it can be done. And so rather than waiting 2 weeks to see how things went, we can understand it continually and then be able to have the feedback. It shouldn't replace the session we have. It should augment it. Maybe you could think about the fact that you see a therapist in an academic program once in a while, and then the resident sees you in between. I think this opportunity to move from fragmentation to continuity of care, from continuous monitoring and management, from the kinds of feedback that we have today, which is that we only learn about problems when it's a crisis, and instead learn about it before the crisis. I think those are the real opportunities. I want to say the same thing I said earlier, that the empowered patient combined with the dedicated clinician and the technology has the ability to provide care that's going to be 10 to 100 to 1,000 times better than any of the three alone could do right now. And I think that if we can do that, we can move left, move before the crisis strikes so that we can prevent it a third or half or 2/3 of the time. And if we can do that, we'll raise quality, increase health, and lower the cost of this nation.
That would be amazing. Unfortunately, we're out of time for listener questions, but I do have one more question for you. And that is, do you have a favorite quote you can share? And if so, what is that favorite quote?
There are a lot of quotes that I like. I like quotes about no one cares how much you know until they know how much you care, because I think that that is something in medicine that's important and even more important in leadership. But probably I would say, and maybe it's going to teach in the business school, I love that Charlie Munger quote that I said earlier. Tell me your incentives and I'll tell you the outcomes you're going to get. If people want to believe that the American healthcare system is the best in the world right now and that we do a great job of providing care, even though our life expectancy is 5 to 6 years less than other countries, we can tell us that. We can think the incentives are right. But if we think that the outcomes that we're getting, and I don't mean, for just the top 10% of this nation, but if we think overall the outcomes we're getting are the best outcomes, aren't the best outcomes, then we need to question our incentives. And I know that the move from a fee-for-service to a capitated process is going to be very difficult. The transition is going to be painful. But I also know that if we can get to the opposite side and we can align that incentives and use the technology, that we can make American medicine, again, the best there is in the world.
Robert, thank you so much. This has been a fantastic discussion. Thank you so much for joining us today. For our listeners who are interested in your newsletter, podcast, books, or other appearances, what's the best way for them to stay connected to your efforts? Would it be LinkedIn or something else?
The best way is through my website, robertpearlmd.com. If you go there, you can get links to all of the various things I might have written, to the podcasts themselves. If you have feedback, hopefully you buy the book ChatGPT MD, How AI Empowered Patients and Doctors Can Take Back Control of American Medicine with All Profits to Doctors Without Borders. Be a great holiday gift. You have feedback. You disagree with me. You like the ideas. You've implemented them. Let me know. You can connect to me directly through that source, my website, robertpearlmd.com.
Great. To our listeners today, thank you for joining us as well. We hope you found this discussion informative and inspiring. I'd also like to thank Steve Peltzman and his team at Feedback Now for sponsoring our program. And be sure to join us for our next episode on December 12th at 1 p.m. for our next Humanizing Healthcare discussion. I'll be talking with Gianluca Moro, a leading artificial intelligence expert, author, and founder of the AI Academy. He was one of the keynote speakers at the recent 2024 Planetree Forum. It was very interesting, had a lot to say in helping us understand AI at a basic layperson's level and how it will apply to healthcare. It's a conversation you won't want to miss.